Welcome back to The Explainer. Today, we're diving headfirst into the brand new 2024 AOCA-PO Consensus Report. We're going to demystify dental implant diseases and reveal exactly how to protect those smiles. Look, whether you're relying on dental implants yourself or you're the clinician placing them, this data, it's absolutely vital. Let's get right into it. Here's our roadmap for today. We're covering 5 key areas: the dental implant boom, 2 major implant diseases, key disease risk factors, treating early inflammation, and finally, tackling advanced bone loss. Let's start with Section 1, the dental implant boom. To put things in perspective, globally, over 1 million patients get dental implants every single year. 1 million. Now, on one hand, this is a massive functional and aesthetic success story, right? Implants restore confidence, they restore chewing ability for a huge number of people. But as this consensus report firmly points out, this surge in placements has concurrently brought a heightened incidence of long-term biological complications. It's rapidly growing into a serious public health concern, and honestly, we just can't afford to ignore it anymore. And this epidemiological data completely shatters that dangerous myth that implants are a permanent set-it-and-forget-it kind of fix. It reveals that up to 47% of patients experience early peri-implant inflammation. Think about that. That's nearly half of all patients. So, if you thought implants were somehow magically immune to the types of infections that natural teeth get, well, the data strongly says otherwise. Which brings us to Section 2, 2 major implants diseases. So what actually happens when things go wrong? Well, it usually starts right here with peri-implant mucositis. Basically, this is a biofilm-mediated inflammatory lesion of the soft tissues around the implant. In a clinical setting, this means you might see bleeding when you gently probe the area, or maybe some swelling or redness. But, and this is a huge but, the absolutely crucial word here is reversible. At this stage, the underlying marginal bone remains completely intact. The inflammation is strictly 100% limited to the soft tissues. But we have to draw a really hard line right here. If that reversible mucositis gets ignored, it can evolve into our second major disease, peri-implantitis. The data shows this affects up to 22% of patients. And unlike mucositis, peri-implantitis brings a rapid, non-linear loss of supporting bone. And once that bone is gone, that damage is generally irreversible, and it can severely jeopardize the stability of the implant itself. It actually progresses way faster than standard gum disease, which is exactly why catching it at the mucosite stage is just paramount. Moving right along to Section 3, key disease risk factors. Now that we understand the incredibly high stakes here, let's look at the specific risk factors that trigger these diseases. The consensus identifies a pretty fascinating dual threat. First, on the patient level, you've got behavioral and systemic risks. We're talking about current or former smokers, uncontrolled diabetes, obesity, and particularly a history of periodontitis. But, equally important are the surgical site factors. The clinician's choices matter just as much. Site-specific surgical errors like malpositioning the implant in the bone, placing it too subcrestally, or placing it in an area with a thin soft tissue phenotype, those things massively increase the risk of disease onset. It's really this critical interaction between the host's biology and the mechanics of the surgery itself. And this risk actually extends right into the prosthetics too, the actual teeth built on top of the implants. The way a crown is designed can actively cause bone loss. The evidence shows that if you have a restorative emergence angle of over 30 degrees, it literally creates an environment that traps biofilm. Similarly, if the transmucosal abutment height is shorter than 2 millimeters, or if implants are placed less than 3 millimeters apart, you are significantly bumping up the risk for bone loss. The hardware itself literally dictates whether a patient can effectively clean the site or not. Let's look at Section 4, treating early inflammation. Okay, so armed with the knowledge of what causes these issues, what happens if reversible mucositis actually strikes? The clinical protocol for early inflammation is super clear. When you can see inflammation, but there's no bone loss yet, non-surgical mechanical debridement is absolutely your first line of defense. But take note of the tools. They absolutely must be implant safe. We're talking titanium curettes, specific ultrasonic tips, or air powder abrasion. The whole goal here is to aggressively remove that biofilm without scratching or damaging the titanium surface of the implant fixture. Now, let's say that mechanical debridement is done, but the inflammation just stubbornly persists. Well, then clinicians have to escalate to adjunctive therapies. This includes localized antimicrobials like minocycline microspheres, or in some instances, very specific systemic antibiotics to help knock down that microbial load. The consensus also points out an interesting fact. Probiotics, specifically certain strains like lactobacillus, might actually help rebalance the oral microbiome in non-smokers to reduce that inflammation. But hey, here is a truly vital takeaway. The consensus meticulously evaluated what does not work, which is just as important. They found that the routine use of lasers over standard debridement or hydrogen peroxide irrigation actually lacks strong clinical support for mucositis. And honestly, this is shocking, but the data reveals that absolutely no adjunctive therapy significantly improves outcomes for active smokers or e-cigarette users. Essentially, if the patient is smoking, the extra treatments just completely fail to overcome the damage caused by the habit. Finally, we arrive at Section 5, tackling advanced bone loss. So let's explore the clinical protocol when the worst happens, when reversible inflammation gets ignored and turns into destructive, bone-eating peri-implantitis. Surprisingly, even with severe, confirmed bone loss on an X-ray, treatment still begins conservatively. Minimally invasive, non-surgical therapy is always step one. The clinician has to attempt to aggressively reduce the microbial load and calm the local inflammation using mechanical debridement before they ever even think about picking up a scalpel. You have to establish a baseline of hygiene and tissue response first. From there, the clinical escalation path is very clear and highly structured. Step 1 is mechanical debridement. Step 2, enforcing perfect home care and patient plaque control, followed by a thorough reassessment of the tissue. If, and really only if, deep pockets fail to respond to those titanium curettes and the patient's stellar oral hygiene, then non-reconstructive or reconstructive surgery becomes the necessary next step. That surgery aims to either reshape the bone to make it cleanable again or attempt to regenerate the lost bone entirely. Ultimately, this incredibly detailed consensus report proves one overarching truth. To prevent these rapidly accelerating diseases, your implants require the exact same rigorous daily care, plaque control, and professional maintenance as your natural biological teeth. You literally cannot just set them and forget them. Implants demand a preventive mindset from everyone involved, from the surgeon designing them right down to the patient living with them. So the question you have to walk away with today is this: are you truly treating your implant like a real tooth? Thanks for joining me for this explainer, and keep learning.